next speaker, Dr. Abdulwahab Albabtain. I think he's the most joyful consultant I have ever met. He's a consultant of hematology and head of section of lymphoma and myeloma at King Faisal Specialist Hospital, RC Riyadh. He's gonna talk to us about CAR T cell therapy and bispecific and indolent non-Hodgkin lymphoma. Dr. Abdulwahab.
Thank you. Thank you very much. Seems like the audience is excited to see me. Let me just work my gadgets here. Okay. All right, these are my disclosures. None of these are influencing my decision, I think. This is my talk overview. We'll be speaking generally about the T-cell redirecting therapy, moving on to CAR T and bispecific in follicular, mantle cell, CLL, diffuse large, and then a summary. So I need to do all of that in 20 minutes. So we'll be running. Okay, so this is a panoramic view of the therapeutic landscape in diffuse large B-cell lymphoma. For 20 years, 1997 until 2018, there was sort of a drug development drought. So only rituximab was there until axi-cell, T-cell came along. However, in the past 4 years, it's been crazy. Drug development skyrocketed, led to the approval of several therapeutic classes, including antibody-based therapy, tafasitamab, Lonca-T, and then the cellular therapy starting marching to the first line, the second line, and soon to the first line. So, and for the first time ever, we've had a new drug in the first line setting, which is POLA added to R-CHP. Not everyone adopted this, but this is an exciting time. That's the message. So, similar to diffuse large B-cell, follicular lymphoma, drug development also expanded in the past 6 years, mainly because of the T-cell engagers. Let me, take a moment to, explain this. It is a very exciting time for two reasons. We have new drugs, but also we have a T-cell engagers or T-cell-based therapy. There are two kinds of T-cell engaging, T-cell redirecting therapy. We have the chimeric antigen receptor T-cell, and we have the bispecifics. Bispecifics comes in two flavors. The first flavor is the first generation blinatumomab, which has a single chain variable fragment. And by the way, BITE is a trademark of Amgen, so we don't use that for the other bispecific. And then we have the full antibody that has a full FC region, which is glofitamab, epcoritamab, and mosunetuzumab so far. Okay, so, although they conceptually have the same structure and what, so first of all, what's different about the new lymphoma bispecifics, they all target CD20 so far, unlike the CD19 and blinatumomab, plus they have a full FC receptor. What that brought to us is that it's a full length, so that means longer dosing schedules and less toxicity. But that was impossible. Oh, it's flickering. So we were speaking about the addition of the FC, full FC segment, and the new antibodies gave us an advantage of longer half-life, less frequent dosing, and less toxicity. This was not possible to add the FC receptor previously, the full FC region, because it will make the antibody susceptible to ADCC eradication, but they were able to, the manufacturers, to induce a mutation in that FC region to avoid the eradication. So although we think they're the same, I mean, at least structure-wise and mechanism of action, but the technology is different. So we have a technology, mosunetuzumab uses knobs into holes, and then glofitamab uses head to tail and so on. Epcoritamab uses the controlled Fab-arm exchange, and they also target different clones, CD3 clones. They have different CD20 epitopes. So the mosunetuzumab have a similar epitope as rituximab, glofitamab to obinutuzumab, and then epcoritamab to ofatumumab. Okay, and then we have the almighty, the wonder treatment, the living drug, and the CAR T therapy, which is which basically the beauty of it, it binds the tumor cells in an MHC independent fashion, but with CAR T comes expense and turnaround time and some logistic hassle. Okay, we'll start with CAR T therapy in B-cell lymphomas. We have 4 different products approved by the FDA for 11 different indications. I would say Liso-cel in the past 4 months, they were very busy because they added 3 more indications. Okay, data. Let's start with data. So we have in relapsed refractory follicular lymphoma, 3 different CAR T approved, Axi-cel, Tisa-cel, and Liso-cel. Axi-cel was approved for follicular lymphoma in the relapsed refractory setting through the ZUMA-5 trial. They included, marginal zone patients, around 31 patients, CR rates for the follicular patients close to 80%, for marginal zone is 65, a median follow-up of 17.5 months, median PFS was 40 months, and then for marginal zone, the median PFS is not reached. ICANS grade 3 or more is 19%, and CRS is 17%. What's really important here is that grade 3 or more cytopenia that persists more than 30 days is 34%. That's the reason why I don't like bendamustine, that I'm going to talk about it. So in the ZUMA-5, they looked at the patients who received prior bendamustine. The best bendamustine duration prior to collection is no bendamustine, because those patients in the yellow curve did better than those who even had bendamustine more than 12 months. Those who had it less than 12 months, they did very poorly. Important to note that in the ZUMA-5 trial, there was secondary malignancies, not the T-cell malignancy, but there was a therapy-related MDS and AML in 5 patients of follicular lymphoma and 3 patients in marginal zone lymphoma. The second product to be approved in the relapsed refractory follicular lymphoma is Tisa-cel through the ELARA phase 2 trial. CR rates is close to 70%. They did not have marginal zone patients. After median follow-up of 29 months, median PFS was not reached. ICANS and CRS grade 3 or more is 3 and 0% respectively. Those with POD 24 actually did less favorably, but their CR rates is less by 10%. The third product to be approved in relapsed refractory follicular lymphoma is Liso-cel, and it achieved an astronomical high CR rate of 94%. And this is only for follicular lymphoma grade 1 to 3A. Would say half of the patients have POD 24, median follow-up of close to 19 months, and median PFS and OS was not reached. ICANS and CRS grade 3 or more is 2 and 1%. So this is a summary of the 3 products approved for the relapsed refractory follicular lymphoma. You can note that Liso-cel in particular, which we don't have in Saudi, achieved higher CR rates. Whether these are going to translate to better outcome or not, we'll have to wait. But more importantly, CRS and ICANS are least with Liso-cel and Liso-cel, Tisa-cel and Liso-cel. Okay, what about bispecific and relapsed refractory follicular lymphoma? Mosunetuzumab is the first, was approved in 2022. dosing of mezenotuzumab is basically unique among the other bispecifics, where you have 3 phases. The step-up doses, which is in all other bispecifics, but it has a loading dose where you go, for 2 doses to 60 milligrams, trying to debulk the tumor, and then you go to base dose. And this is for a limited time, fixed duration. You get 8 cycles. If you go into CR, you stop. If you don't go to CR, you get 9 more cycles, and there's no hospitalization required. So this is administered in a fixed duration fashion. Okay. In the phase 2 expansion trial, mezenotuzumab showed a CR rates of 60%, 60%, an overall response rate of 78%. Time to first response is very short, is 1.4 months. And then after median follow-up of 18.3 months, the median PFS was 24 months, and the median OS was not reached, which is excellent. The second bispecific approved for relapsed refractory follicular lymphoma is epcoritamab. Epcoritamab is given subcutaneously and indefinitely until disease progression. It is given weekly for about 3 months with a step-up dosing in the first month, and then you go to every 2 weeks from cycle 4 to 9, and then every 4 weeks from cycle 10 onward. In this phase 2 trial of NHL1, they included 128 patients. CR rates were 62%. Grade 3 or more ICANS were 2. Grade 3 or more CRS was 0 after a median follow-up of 17 months. 2-year PFS was 45%, and OS was 56%. So this is a summary of all T-cell engagers in relapsed refractory follicular lymphoma. I think liso-cel, in terms of CR rates, wins, but has a shorter follow-up. So we need to see that. Axi-cel has a reasonable follow-up and has a reasonable CR rates, but has a higher CRS. Epcoritamab and mezenotuzumab, I think epcoritamab has a higher CR rates, but however, it's an indefinite treatment. So CAR-T in relapsed refractory mantle cell lymphoma, we have 2 products approved, bruxocel and liso-cel. Bruxocel was approved through the ZUMA-2 trial, which initially was started with axi-cel, but they made some modifications in the manufacturing of axi-cel, where they actually eliminated the immature T cells through the production process, and they called it bruxocel. That's it, the same structure. So it was tested on 68 patients. CR rates was 67% after a median follow-up of 35 months. Median PFS was 25 months, and OS was 46. Grade 3 or more ICANS was 31%. And grade 3 or more CRS was 15%. We know that bruxocel has high CRS and ICANS. Great. The second product approved in mantle cell lymphoma is liso-cel, and that was through Transcend NHL trial, the seamless phase 1 trial. The CR rates were, I think, someone took my diagram, but it was here, 74%, hiding in there. Overall response rate was 86%. A median follow-up of 22 months. Median PFS was 23 months, and OS was 18 months. So 37% had ongoing response after median follow-up of 35 months. Any grade ICANS, it's not known that liso-cel causes this degree of ICANS, but it seems like the disease influenced the grade of ICANS as well. So the grade 3 or more for both CRS and ICANS is 9%. So CAR-T in relapsed refractory CLL, SLL, and our leukemia colleagues are jealous right now. They actually, liso-cel is approved based on the Transcend CLL 004 phase 2 trial, and it has the lowest efficacy among all CAR-Ts. Actually, the CR rates is 18%, but if you add CRI to it, it comes up to 24%, but this is for patients who failed BTK inhibitors and venetoclax. Grade 3 or more ICANS is 18%, so this is not seen with liso-cel and other diseases, grade 3 or more CRS is 10%. That's another confirmation that the disease itself influences the rate of ICANS as well. So how did CAR-T transform the paradigm in diffuse large B-cell? Outcomes before CAR-T and bispecific was dismal. Okay, out of 100 that actually relapse, only 10 you can salvage and they'll be cured. The rest are not going to make it. So you need to interpret all the data based on this fact. In CAR-T, in the third-line setting of diffuse large B-cell, we have 3 products, Axicell again, through the famous ZUMA-1 trial, CR rates is 58%, and then we have after 5-year overall survival of 42%. And this is the longest CAR-T follow-up that we have among all the other CAR-Ts. Juliet trial brought to us liso-cel in the third-line setting for diffuse large B-cell. CR rates are lower than Axicell's 39%. And median follow-up, after median follow-up of 40 months, median OS was 11 months. And the third product in the third-line setting for diffuse large B-cell is liso-cel. And liso-cel across all lymphomas have the shortest follow-up. They always come late, BMS. So CR rates is 53%, median follow-up is only 1.5 years, median OS is 21 months, but those who achieved CR, median duration of CR was not reached. Okay, this is a big question. Is Axicell curative in the third-line setting? I think everybody is shying away from answering this question. I think maybe yes. You know, it depends on the definition of cure. I mean, I think, you know, we always discharge our patients after 5 years in lymphoma. And after 5 years, you know, among all patients with or without an an EFS event at 12 months, the 5-year OS in those who did not have an EFS event is close to 90%. Putting that with the fact that 30 patients at 30% had an ongoing CR at the data cutoff, I can say maybe, you know, Axicell in the third-line setting is curative. Okay, in the second-line setting, how long do I have?
2.5 minutes.
Okay, in second line, we know that Axicell made history by coming to the second line through the ZUMA-7 trial, and it actually made history by actually bringing an overall survival benefit, despite the fact that almost, you know, half of the patients were crossovered to Axicell in the standard of care arm, which is fascinating. Liso-cel made it to the second line in diffuse large B-cell through the Transform trial, and liso-cel has no overall survival benefits so far. However, a longer follow-up needed because the median follow-up is only 17 months. Axicell needed almost 4 years to show this, you know, difference. So liso-cel, on the other hand, liso-cel is approved in the second-line setting for those who are transplant ineligible. Axicell is not. Okay, liso-cel has negligible grade 3 CRS, as well as ICANS in the Transform trial, which gives us an advantage over Axicell since they're both approved in the second-line setting. However, Axicell has an overall survival benefit. Okay, this is a summary of all products in diffuse large B-cell lymphoma. Just to remind you that these 4-1BBs, Tisa-cel and liso-cel, have a different, you know, structure, and they do it differently. They have a fixed ratio between CD4 and CD8. So they're different. They're approved. Axicell is approved in the second-line setting along with liso-cel. We haven't talked about the Blinda trial, which was a negative trial. They couldn't make it in the second-line setting. So bispecific and relapse refractory diffuse large B-cell is glofitamab. Glofitamab has a unique structure that is bivalent, so it attaches 2 CD20s. And the dosing is similar in principle to the other bispecifics in a sense that it needs step-up dosing or SUD for weekly doses. And also uniquely, you need to start with obinutuzumab before before going ahead with the step-up dosing to eliminate the risk of, not to eliminate, to reduce the risk of CRS Glofitamab in the third-line setting gave a CR rate of close to 39%. Median duration of response was 18 months. Looks good for third-line setting. And then we have epcoritamab, which is also approved in the third-line setting in diffuse large B-cell after a median follow-up of 10.7 months. The median duration of response was 12 months. And median time to response is very short. The CR rates is identical to glofitamab. So this is a summary of all the bispecifics in diffuse large B-cell lymphoma. Just to let you know, the Saudi FDA approval is for epcoritamab and expected for glofitamab very, very soon. I know it's gonna happen in the next week or so. Okay, so just, I know the whole dilemma of, should we use CAR-T versus bispecific in the third-line setting? There are meta-analyses. This is the meta-analysis that was actually published 6 months ago, and they're favoring CAR-T over bispecific. My take on that is too early to do so. Okay, we just need time, and we need more data, and we need randomized trials, of course. So what about using CAR-T first, then bispecific? The French and Spanish group tried bispecific, then CAR-T, and the efficacy was similar. There was 47 patients only, so take it with a grain of salt. We know from the registration of trials that post-CAR-T bispecifics achieved reasonable, given the historical background of these patients, CR rates of 34 and 35% for epcoritamab and glofitamab. How do I choose between glofitamab and epcoritamab? That's a tough one, but both of them require inpatient stay, okay? I mean, for the first dose at least. But glofitamab does not require steroids after cycle 3 if you didn't have CRS. Epcoritamab does not require obinutuzumab, but glofitamab does. I think glofitamab requires longer intravenous infusion time of 4 hours versus subcut for epcoritamab, get it and get done. But this supplanted, in my opinion, with the fact that epcoritamab is given more frequently and indefinitely, whereas glofitamab is given in a fixed duration manner. After all, I think cost effectiveness is what's going to be the most important determinant of choice between these two agents. This is how I treat diffuse large B-cell. This is how I treat follicular. Sorry, we're running out of time, right? Because I want to share something very important. Huh?
Go on.
I think I have 3 minutes. Let me go back.
You get 30-second extra stoppage time.
30 seconds, okay. Okay, so we've submitted our axi-cell experience to ASH this year, and our champion, Dr. Sahibani, is not here. Dr. Hijab, shout out for you. I wanted to put your picture there, but you didn't want it, okay? So our outcomes, we've actually analyzed the first 50 patients. We've done 74 patients, but we were able to analyze these 50 patients. Actually, 38%, 19 patients were second line, 31 was third line, 31 patients third line. Second line response rate was, CR rates was 58%, which is 11 patients out of 19. CR rates in the third line setting is also 58%, which is 15 patients. CRS and ICANS, actually we have very few grade 3 or more CRS, but we had significant ICANS and 16% in second line and third line. So this is our outcome at 12 months. OS in the second line setting was 94%, and I think because we gave all of those patients glofitamab after they relapsed, that's why they're still alive. Third line setting, the 12 months OS is 68%. At 12 months, PFS for second line is 56.8%, and the third line PFS is 53%. So we submitted also our glofitamab experience, and this is an opportunity to shout out to Roche. They were honestly above standard in their compassionate use program. We were able to treat so far 48 patients in our program. We've analyzed the first 30 patients, and we're analyzing the whole cohort as we speak. We submitted that to ASH. CR rates were 26%. A little bit disappointing, but those patients are heavily pretreated. By the way, most of those patients, around 75% of the 76% had prior CAR-T. This is the median follow-up. This is the outcome of our gliflozin experience. At 12 months, PFS and OS was 14% and 17%, respectively. So this is my team. This is me. They come on. This is Dr. Hazza. This is our heme team. Usually we're double that number, but we were voting regarding the actually the management of one of our difficult patients. After half an hour of very long discussions, that was the vote at the time, and Dr. Sayed took that picture. So proud of them. Before I move on, I'd like to say one thing about our gliflozin program that we had in association with Roche. We've had a very successful experience in the compassionate use program throughout the last 3 years. They were truly givers. They worked day and night to supply gliflozin for our patients throughout the weekend. In the holidays, I'd like to shout out for Karim Al-Hanafi. He worked from Egypt, he worked from everywhere in the world and to supply those patients, because by day 30, we knew that our patient is progressing and we needed 3-4 days, 5 days maximum to start gliflozin, and Roche was able to deliver that. Thank you very much. We'll take a quick moment to ask Roche team to come to the podium to honor them and appreciate and show the appreciation, please. We need the certificate, please. I think, it's not an exaggeration to say that you guys helped us save lives. Yeah, so this goes to the Compassionate Use Program. Thank you very much. Yeah. Yeah. Thank you. And this one goes to Mr. Karim for working relentlessly throughout the 3 years. Thank you very much, Karim.